Hello, my name is Jari Kempers. I'm a health economist. In this video, I'm going to present you the results and recommendations of an economic assessment of introducing community medical assistance in primary care in Moldova. I have done this work together with Dr. Alexander Stopa, and this work was commissioned by the Swiss Tropical and Public Health Institution and funded by the Swiss Agency for Development and Cooperation. You can find more about this project in a short 4-page policy brief which is available in English and in Romanian. You can find the download links below this presentation. At the time of conducting this study in March 2020, the Ministry of Health of Moldova is preparing for a new regulation for the introduction of community medical assistant CMA services. The purpose of this policy brief is to support this by providing new inputs and insights and carry out the national level assessment of the resources needed for the implementation of the CMA service. We look both financial and personal. Let's start with the human resources. How is it decided where the CMAs should work? In this analysis, the following allocation criteria was used. First, the CMAs are assigned to the health centers according to the total catchment populations. This includes the sub-facilities as well. Second, both rural and urban health centers are entitled, except urban facilities in the larger cities of Chisinau and Balti. Fourth, we used the ratio 1 CMA per 2,000 persons. This is higher than what has been currently discussed, but we chose this because we believe that this is already an optimistic projection. Applying a lower ratio, like 1 CMA per 1,500 persons, would require much larger number of CMAs and much more time, and we believe this is not feasible. Fifth, managers of the health centers decide which communities the CMAs should work, and therefore part-time sharing the CMAs between the communities is possible. How many CMAs are then needed? Based on these criteria, the national coverage would require 1,089 CMAs. A new CMA should be hired for a new position. One should not shift the limited human resources from health centers to communities, but focus on growing the medical workforce. This would mean a gradual 23% increase of the number of medical assistants and CMAs working in the primary healthcare. There's a technical annex where the number of CMAs per health center is documented. Currently, 4,745 medical assistants, MAs, work in the primary healthcare. My next point is important. The current MAs should not be transferred in large scale from the understaffed health centers to CMA services without first hiring new MAs to fill their positions. Otherwise, simply moving 1,000 MAs to community work would decrease the health service capacity of the primary healthcare as a whole. How will the CMAs be trained? There are 2 training streams: on-the-job specialization training of existing MAs and a new CMA education in medical colleges. 113 CMAs were trained through the on-job specialization training 2006 to 2009. This is a quick way to start, but it is not a long-term solution. These training volumes are simply not sufficient for reaching the national coverage. Currently, there's a cap of 976 trained CMAs. In this analysis, we assumed 100 current MAs to be trained as a CMA per year. This is a double of the current training volume. Then the CMA education in the medical colleges. This is a long-term national level solution. However, this education has not yet been started. The duration of the education is 3 years, so even if the education was started today, there will be a 3-year delay. In this analysis, we assumed that 235 new CMAs graduate from the medical colleges each year. This would mean that a quarter, 26% of all the MA graduates would have a CMA specialization. We also need to take into account that only 66% of the medical graduates continue in their profession in Moldova. How long would achieving full national coverage then take? So we assume 335 new CMAs to be trained, 100 through the on-job specialization and 235 from the medical colleges. Moreover, the work of CMAs is demanding and the salaries are low. Therefore, a high 20% annual staff turnover was assumed. Here we see the prediction. The red line is the number of CMAs needed, 1089, and the green bars are the number of CMAs working. With the previous training numbers, achieving the national coverage would take 10 years, and I consider this to be an optimistic scenario. Here we can see that the numbers start to only increase after 3 years when the first graduates begin to come from the medical colleges. Let's move then to the cost analysis. How much will the CMA services cost between 2020 and 2025? As the number of CMAs working grows, the annual cost would increase, reaching 55 million by 2025. Total investment for this period would be 207 million Moldovan lei. This would mean that on average one CMA costs 70,600 lei per year. How will the funds be spent? The salaries are the largest cost component by far, 83%. It's larger than the other costs combined. This was as one would expect in a labor-intensive profession like CMAs. The material costs were 7%. This includes the minimum equipment and consumables for the CMAs, although there is a broader recommended list for the materials as well. Workspace, 5%. It was assumed that each CMA would have an own consultation room in the primary health care facility or provided by the local authorities. Transport, 2.6%. In order to do their work, the CMAs need transportation, and this needs to be budgeted. And the other costs, including mobile calls, refresh trainings, and some prevention materials. You can find more details on the costs in the policy brief. How does this then relate to the current primary healthcare capitation payment? The CMA service is a new permanent part of the primary healthcare, and therefore the capitation payment should be increased by 30 lei per capita to cover the cost of the new CMA service. This would mean an increase between 4.2 and 10.8% per capita, depending on the age group and whether a rural adjustment is applicable. Obviously, this would be paid only to the health centers that provide the CMA service with the additional new CMAs and not in situations where the current MAs are just shifted to the community. Here's a summary of the results. So we would need 1,089 CMAs to reach the national coverage. One CMA costs 70,600 lei per year. The total investment needed for the period 2025 is 207 million lei, and the capitation payment should be increased by 30 lei per capita. Then 5 policy recommendations arising from the study. To achieve the national coverage in 10 years, train at least 335 new community medical assistants per year. 2. Continue and scale up on-the-job CMA specialization training to at least 100 current MAs per year, and when doing this, new MAs must be hired for the old positions. 3. Start and scale up the medical education of CMAs in the medical colleges urgently. At least 235 new community medical assistants should be graduated each year. 4. Hire new CMAs for the new CMA positions. Do not shift the limited human resources, but focus on increasing the medical workforce. 5. Use the current primary healthcare capitation payment system to finance the CMA service. The National Health Insurance Company should increase the primary healthcare capitation payment by 30 lei per capita to cover the cost of community medical assistance service. I would like to thank these persons and organizations for their support for this study. And please remember to download the policy brief from the links here under. We hope that these inputs and insights will be useful for drafting of the new CMA regulation. Thank you very much.